Good afternoon, everyone. I am Dr. Ruchika Sood, Associate Consultant in Fertility at Fertility IVF and Fertility Center, Delhi, and I will be the MOC for the CME. It gives me immense pleasure to welcome all the dignitaries, seniors, and dear friends to this exciting CME on behalf of IFS SIG Endoscopy, IFS Uttrakhand chapter with Gynae and Obs Society, Dehradun. In this webinar, we will be discussing a very important topic, that is fertility enhancing surgery, common challenging scenarios in ART practice. Fertility enhancing surgery plays crucial role in artificial reproductive technology practice, addressing various challenging scenarios to improve the chances of conception. There are various conditions leading to infertility which require surgery, but two very important challenges we face in day-to-day practice are myoma with infertility and persistent thin endometrium. And we have excellent speakers, experts, and chairpersons who are stalwarts in the field of infertility to discuss about these two conditions. Now, without any delay, I would like to invite Dr. Mansi Jain for welcome address. She is a consultant reproductive medicine and gynae endoscopy surgeon at KJ IVF and Laparoscopy Center, Delhi. She is a co-convener SIG Endoscopy, IFS 2022 to 2026. She's an executive member IFS 2024 to 26 and also a national coordinator SIG IFS. Over to you, ma'am.
Thank you, Ruchika, for such a nice introduction. So, good afternoon, everyone. It's my pleasure to welcome you all for this webinar today on behalf of SIG Endoscopy. Before we proceed with the academic session, I would like to give you all a brief info about our SIG. So, basically, SIG Endoscopy is a specialized group of IFS which deals exclusively with endoscopy practice and infertility. We have a very dynamic and a passionate team, which is mentored by Dr. Kuldeep Jain, and the convener is Dr. Parul sir and Dr. Deepak sir from Kota, and myself. We are the co-conveners. So it is a constant aim to promote and propagate the right and the ethical practice of endoscopy, especially in the infertile population. And this year is a really jam-packed year. We have lots and lots of activities planned, both at the academic and the research front. This year, we are also having a special segment where we aim to involve a lot of youngsters, everybody who is less than 45 years of age and who are interested, who are passionate about surgery, who are passionate about endoscopy. So we invite them to come be a part of our active team. They can contribute in our academic and research activities. They can also they get a chance to share their innovative surgical ideas and anything on our platform. So with that, I hand over the session back to Ruchika, and hopefully we have a good webinar.
So we will be having one, ma'am. So next, I would like to invite Dr. Ritu Prasad for welcome address. She is a director at Prasad Hospital, Rishikesh, Prasad Navankar Test Tube Baby Center, Dehradun. Ma'am is presently working as a chapter secretary IFS Uttarakhand. Madam has been awarded with Sushma Swaraj and Himalayan Ratan Award, IFS Achievers Award 2022, Indra Priyadarshini Award 2023, and ISAR Appreciation Award 2023. Please, ma'am.
Hello. A warm good afternoon to all. It's a pleasure for me to host today, to be a part of IFS SIG Endoscopy webinar as a chapter secretary of IFS Uttarakhand. It's a great honor for me, and I welcome Dr. Kuldeep Jain sir, the organizer and the main showman behind this endoscopy workshop. I also welcome the expert, Dr. Parul Kotwara, and our two experts from here, Dr. Aarti Marwa and Dr. Hariom. And I also welcome the two speakers, Dr. Deepak Desh and Dr. Mansi Jain. and our coordinator, Dr. Ruchika Sood. Because no any conference webinar is successful or accomplished without a teamwork. And we know that right teamwork right from starting the invite and calling all the chairpersons together and getting under one head. So let's discuss today an important topic of dealing myomas in infertility, the laparoscopic aspects by Dr. Desh Deepak would be our first session, and next session would be covered by the convener, Dr. Mansi Jain of severe endometritis. So we can start the session now.
Hello. May I audible, madam? Hello. आवाज आ रही?
Yes, sir, you're
Yes,
audible.
sir, you're
Please
audible.
continue.
Thank you. Respected chairperson and my dear friends, and respected Kuldeep Jain sir, Kotadwala sir. Today my topic is the different aspects of the myoma in infertility, laparoscopic approach. So why we should remove the myoma in cases of the infertility? It is very clear that myoma can cause endometrial vascular disorders and inflammation, which result in non-conducive environment for embryo implantation. With the presence of the intramural fibroid, the HOXA, A10, and glycoderine are reduced during the implantation. The myoma also disrupt the junctional zone, which increases the uterine peristalsis and cause implantation failure. So this is the diagrammatic representation how the myoma can cause infertility, and so any myoma which is more than 4 centimeter needs to be removed as they alter the OXA10A and glycoderine levels which are essential for the implantation. Myoma also engages the uterine peristalsis because of the pseudo capsule. There is neurotransmitters which are produced by the pseudo capsule, so they can increases the uterine peristalsis, and also there are many factors like oxytocin, prolactin, which is also increased where there is myoma, which also affect the endometrium and implantation. So this pseudo capsule is very important in two aspects. One is that whenever we are doing the myomectomy, we should preserve the capsule. So if we preserve the capsule, then there will be good healing after the suturing also. So this is the again whenever we are planning any case of the myomectomy, it is very important that we should proper do the sonography and we should proper do the mapping of the fibroid. So FIGO classification that all the myoma which are present inside the cavity should be like 0, 1, 2. They can be diagnosed by saline infusion sonography and they can be removed hysteroscopically. So today my topic is that how we can do the myomectomy laparoscopically. So the myoma like 2 and 3, 4, 2 to 5 hybrid myoma, they all can be removed laparoscopically. So there is always confusion that what should be the size of the myoma which can be removed laparoscopically. In all cases of the submucous myoma which are more than 4 centimeter should be removed laparoscopically. And why they should be removed laparoscopically? Because if we do hysteroscopically myomectomy and myoma is very big, then the chances of the fluid absorption and there will be big rent. So the scar will be also weak. So before planning any myomectomy, proper clinical examination is also very important. Transabdominal sonography and transvaginal sonography with 3D application, so that we can do proper mapping of the fibroid. Saline infusion sonography to rule out the submucous myoma, and we can see the vascularity of the pedicle also. So if suppose if there is any confusion, then we can do the office hysteroscopy to see if any submucosal component. MRI in cases of the big myomas and to differentiate between the adenomyoma and myoma. So intravenous pyelography can also be done if there is broad ligament fibroid, because there is chances of the ureteric compression also in these cases. So before doing myomectomy, we can arrange the blood. We can explain the patient. There is sometimes chances of the conversion into the laparotomy also. Post-operative risk of the hemorrhage and recurrence also. This can be also explained to the patient. and need of cesarean delivery after the myomectomy can be explained to the patient. So right instrument are very important before doing the myomectomy. We should have the infiltration needle for suppression infiltration, harmonic scalpel or monopolar hook, scissors, myoma screw, tenaculum, tooth grasper, needle holders. We can have two needle holders, section cannula, non-tooth grasper, bipolar energy source, bipolar cutter, straight scissor, modulator, and in back for content modulation. So ergonomics is very important whenever we are doing the myomectomy. We can always see the size of the myoma. According to size of the myoma, we can plan the our port position. Our port should be at least 4 to 5 centimeter above the topmost portion of the fibroid. Distance between the accessory port should be more than 4 centimeter. Method of the port placement may be direct port entry, or if you are comfortable the varies, then you can adapt according to your plan. So you can see that if you are using middle port, so the port position is like that. If you are using the ipsilateral port, then port position is like this. So first, whenever we start the myomectomy, our first step, how we can reduce the blood loss. So to reduce the blood loss during myomectomy, you can use the vasopressin that can cause vascular spasm and uterine muscles contractions. So dose is 20 units per ml dissolved in 200 ml of the normal saline. Indication for the vasopressin is the medical history of angina, myocardial infarction, cardiomyopathy, migraine, asthma, and COPD. So if the vasopressin is contraindicated, then we can do the uterine artery ligation at its origin to prevent the blood loss during the myomectomy. So again, all the submucous myoma, the gold standard is that should be removed hysteroscopically. But if the size of the myoma is more than 4 centimeter, so we can plan the laparoscopic myomectomy. So all the guidelines is there that we can properly measure the size of the myoma, and we can see whether how much the myoma is inside the myometrium, how much the myoma is inside the cavity. According to that, we can plan the laparoscopic myomectomy. So risk of the rupture of the is more when we do the hysteroscopic myomectomy in large myoma. So now it is proven that laparoscopic myomectomy is better in cases of the large submucous myoma, in cases of the myoma which is more than 50% in the intramural myoma. So this is the my first video where there was a submucous myoma, but it was hybrid myoma. It was a hybrid myoma from 2 to 5, means that there is a nearly 1/3 component inside the uterine cavity and 2/3 component in the myometrium. So initially we have started doing the myomectomy hysteroscopically, but patient want that my myoma should be removed in one sitting. So half of the portion of the myoma is removed laparoscopically. So there is a question why you did the half hysteroscopically and half laparoscopically, because sometime if the cavity is open, there is no any I think harm. So in this case, I can tell you that this patient conceived after 3 months of the myomectomy, and we have delivered this patient at the 38th week of the pregnancy. So if the cavity is open, so then there is no any worry. And whenever we are doing myomectomy, traction and counter traction is very important. The role of the assistant is very important. So you can see in this video that there is ipsilateral port. In the right hand, I am using the harmonic scalpel, and sometime you can see we can change the position of the myoma screw according to the traction. Whenever we are reaching at the base, there is some blood vessels. Those blood vessels should be coagulated with the harmonic scalpel. You can see that distension media is also coming from the cavity. So in this case, cavity is open, but if the cavity is open, then we should suture the defect in 3 layer. So nowadays, as far as suturing is concerned, we are having good barb suture, that is statafix suture, known as statafix. So this is the statafix with two needles. So first we take the full thickness suture. After taking the full thickness, then in the second layer we can take the whole myometrium, and after taking the myometrium, then we can take the serosal layer. So after closure, there should be no any dead space. The main aim is there should be no any dead space. There's no any bleeder inside the cavity. Suppose if there is any hematoma in the bed and we have opened the cavity, so that hematoma will drain from the uterine vaginally. So there is no any problem if you have opened the cavity. And you can see that our final closure, the line should be very smooth. And so if there is no any exposure of the myometrium, the post-operative chances of adhesion is very less. Video. So this is the happy couple after the myomectomy. Again, I have taken the case where there is posterior wall myoma, and in this video, we have did the myomectomy only laparoscopically, but this was a nearly 6 centimeter myoma, which was occupying whole of the cavity also and indenting to the posterior wall of the uterus. So before doing myomectomy, you can do hysteroscopy also, laparoscopy also, see the where the myoma is arising from the anterior wall or posterior wall. You can, according to serosal bulging, you can see from the round ligament whether it is a posterior wall or whether it is an anterior wall. So in this case, after enucleation of the myoma, and in all cases of the posterior wall myoma, our incision should be oblique. So we can get the more space for the enucleation of the myoma. So in site of the incision, how much is the incision depend upon the size of the myoma. Always try to prevent any injury to the cardiac structure, any pressure effect near the fallopian tube. And you can see this is the base ball suturing, inside out, inside out. So after the base ball suturing, all the dead space is closed and serosa of the defect come very close. So in cases of the myomectomy, your suturing should be very good. You can do suturing with ipsilateral port. You can do suturing with contralateral port, and you should able to do suturing from the middle port also in cases of the posterior wall myoma. So this is the one of the video of the posterior wall myoma. After this, again, we can see that there is one patient where all the videos which we have selected, all the patient conceived after the myomectomy. I have selected only those video where we did the myomectomy, and after 3 months, 4 months, 6 months, patient conceived and delivered also. So in this case, suppose you are planning for the myomectomy, it is very important that we should see other factor also. Like if there is any tubal block, then we can do the tubal convolution. If there is any cervical stenosis, so we can do you can see here there is a patient who is having cervical stenosis also. So before going inside the uterine cavity, there was stenosis at the level of internal os. So we cut at the 3 o'clock portion and at the 9 o'clock portion to relieve the stenosis. So this is the laparoscopy picture of the same patient. So you can see there is fat deposition near the fallopian tube, but both tubes are blocked. So we did the convolution also, and dye is coming from both the tubes. So you can see dye is coming from the left tube. Hysteroscopy and laparoscopy is done at the same time. In the upper video, you can see the tubal convolution. In the lower video, you can see the tubal patency test. So after proper hysteroscopy and laparoscopy and tubal convolution, if there is any adhesion inside the uterine cavity, we can treat at the same time if we are doing the laparoscopic myomectomy. So in this case, there is anterior wall myoma, there is posterior wall myoma, and the one myoma is very close to the left fallopian tube, and that is the in the lateral wall of the posterior wall of the uterus. So in cases of the, suppose if there is any anterior wall myoma or subserous myoma, so we can do elliptical incision also. Top of the myoma,
Hello. Session is concluded.
I think, ma'am, we lost the transmission somewhere.
हाँ नहीं
Dr. Deshti.
चल रहा था.
Sorry.
It was very nice.
I was thinking it's just me. I'll just get in touch with them. You just wait for.
No. Actually, sir has very rightly shown that we are quite a time afraid that we have opened the endometrium and the patient will not conceive. But he has shown that video in which the endometrium was opened, and we should not be afraid and be guilty that we have opened the endometrium.
Excuse me. Excuse me.
Yes.
Yeah. Yeah, there is some issue in internet. It's just starting.
Dr. Parul, any views on this?
Yes. I would like to share something.
Yeah.
See, cavity opening is not an issue if it is unavoidable. If it is avoidable, it is better to avoid touching the endometrium. When we go for resectoscopy, then a large area of endometrial defect will happen. Because the large surface over fibroid is there, and we will resect a lot of endometrium. That is likely to cause fibrosis and impact the fertility later. So I would be of the opinion that as long as possible, avoid damaging the endometrium. I'm not saying that something wrong has happened, but purposefully cutting the endometrium, I am not very convinced of. Okay. To drain the hematoma, that is an argument put forth sometimes. But then when you are suturing full thickness, the hematoma may be trapped anywhere in the suture line. It will not be always open on the inside. So that purpose perhaps is not correct to keep the endometrium open. Okay. And secondly, we are using resectoscope, which is causing cauterization. And cautery on endometrium has a more preponderance for adhesion formation. And of late, as you perhaps know, that all our septum and everything, we try to go for mechanical cutting and avoid the cautery inside the
Cautery. Yes,
okay.
very
So
true.
that was one point which I wanted to highlight. Otherwise, quality of surgery is excellent. And I must compliment Dr. Deepak. I think his
Dr.
video
Deepak
was there.
joined,
So,
I think.
hello.
so let's
Yes, sir.
continue. Yes.
Sorry for interruption in the connection because share. Hello.
Yes, sir, you are audible. Your video is also seen now on the screen. Multiple fibroids. Somebody from the IT, Ruchika?
Yes, ma'am, I'm contacting them.
Because many people have joined now. Dr. Deepak, some connectivity error from your end? Internet problem?
I've spoken to the IT person. He's saying there is some issue with the connectivity from his side, from Sir's side. So I think in the meanwhile, the session will not be completed until and unless we invite our experts and chairpersons. So first of all, I would like to invite our first expert, that is Dr. Kuldeep Jain sir. He is a renowned figure in the infertility and he does not need any introduction. Sir is a laparoscopist, infertility and IVF consultant and director at KJ IVF and Laparoscopy Center at Delhi. Sir is currently mentor IFS SIG Endoscopy and was a founder, secretary and past president IFS. Sir has published more than 35 research papers in national and international journals and has more than 300 invited lectures, keynotes, oration. I welcome you, sir. Our next expert is Dr. Aarti Luthra, ma'am. Ma'am is fertility specialist and gynae endoscopy surgeon, Luthra Hospitals. She's a joint secretary UPAI IAGE 2021 to 24. Ma'am has received many awards, including ISAR Appreciation Award for Assisted Reproductive Technology 2024, Bhubaneswar. Next, I would like to invite Dr. Hariom Prasad. Sir has done his MBBS from KGM, Lucknow, MS Masters in Surgery from SN Medical College, Agra. Sir has received training in laparoscopy from India and abroad. I welcome all the experts to our CME. I would like to welcome the chairpersons for this session. The first chairperson is Dr. Upender Oli. Sir is head and director Oli Hospital Infertility Research and Diagnostic Center, Haldwani, Nainital. He is practicing as infertility consultant since 1994 and is also working as clinical embryologist, sexologist, as well as counselor. Sir has established first infertility and IVF center in Kumaon. Next, I would like to invite Dr. Radhika Ratori. Ma'am is a private practitioner at GR Hospital, Dehradun. She has special interest in high-risk obstetrics and infertility. Ma'am has attended various medical screening camps and is working with NGOs for awareness programs. Until Sir Dr. Deepak sir joins us, maybe our experts can put in their important comments and anything.
Thank you, Ruchika. I think there's Deepak is struggling with his presentation, so we can open some discussion on because Dr. Parul is here and a lot of other people are here. So, but I will like to, as a fertility consultant and as far as even laparoscopic surgeon, the most important thing which I feel before putting a knife for myoma, we need to know how to decide whether this myoma is going to give a better outcome and the surgery is required, because that is very important. And most of the time there are few debatable issues, especially when we are dealing with a intramural myoma. Now, when we are planning to do myomectomy in intramural myoma, which myoma should be removed? Because there is no debate as far as the submucous myoma is concerned. Even if it is a small submucous myoma, it should be removed. That is, there is lot of literature available, and the recommendation is submucosal myoma, they do affect implantation and fertility rate. So they should be removed. So there is no debate. There is no debate on subserous myoma also. Even if it is a large myoma, it doesn't interfere with implantation. So they can also be left out. Now, debate is there, what should be done to intramural myoma, especially small myoma, 3 centimeter, 4 centimeters, should they be removed?
Sir,
There are some guidelines. Yeah, this Deepak, are you on?
yes, sir. Yes, sir.
Okay, so you can continue your presentation. We will discuss later on. You finish your presentation.
Thank you, sir. Sir,
Okay.
any myoma which is more than 4 centimeter touching the endometrium should be removed.
Again,
Yes, sir.
we will discuss it once you
Last wale le lo.
complete the
Last wale.
presentation.
So, sir, previously I have shown the anterior wall myoma, then posterior wall myoma. All the myomas are more than 6 centimeter, and they all are the touching the endometrium. So, this is another case where there is multiple myomas, and the patient was having the infertility also. So, in this case also, we did the myomectomy, and after the myomectomy, patient conceived. So, we have selected those cases where we did the myomectomy and patient conceived after the myomectomy. But we have also uh, at the time of the myomectomy, we have also corrected other factors also. Whenever we are doing the myomectomy, we do hysteroscopy also. Whenever there is myoma, there is some chances of that patient will have the multiple polyp also. And with myoma, in this case, there was septa also, and the uterine cavity lateral metroplasty also done in this case. So laparoscopic surgery always, in cases of the infertility, we combine the hysteroscopy simultaneously. So if we reduce the pressure at the time of the hysteroscopy, any myoma which is indenting inside the uterine cavity, according to me, those myoma should be removed. So in this case, why I have taken this case, because sometime after suturing there is some myometrium is exposed. So in these cases, we can use the intersheath to prevent the further adhesions. And because this patient was having multiple myoma and posterior wall, anterior wall, lateral wall, so after suturing there was some exposure of the myometrium. So in these cases, we use the intersheath to prevent the post-operative adhesions also. That is also very important point. So this patient, after multiple myomectomy in the different incision, like one incision anteriorly, one incision posteriorly, and one incision on the lateral side. And ultimately, she conceived and delivered at the 38th week of the pregnancy. So these are the subserous myoma in the same case. There is posterior wall myoma, intermural myoma in the same case. So after so in the last, you can see here that we put the intersheath so that there will be no post-operative adhesion. So in this case, I want to show if there is multiple myomas, and in those cases, if the myometrium is exposed, then also we can use the same. So, and this is the last case to show the complication of the myomectomy. So this patient was came to us that she was having anterior wall myoma. Sometimes there is a confusion according to sonography, and some report shows the lateral wall myoma, but that was a true broad ligament fibroid. So in such cases, it is very important to see the ureter. Why I have taken this video? Because you can see the peristalsis of the ureter. We did the ureteric dissection up to here, but we have not done the ureteric dissection up to the uterine, up to the bladder insertion. So this was because this was a true broad ligament fibroid. So the in this case, the ureter was totally shifted medially, and when we are doing the myomectomy and doing the enucleation of the myoma, few fibers of the ureter was totally attached to the capsule of the fibroid. So in this case, you can see that I just want to show the complication of the myomectomy in cases of the broad ligament fibroid. So there was a ureteric injury. So at the same time, if you identify the ureteric injury, you can repair on the table. That was the plus point. So in this case, we did the ureteric catheterization. You can see we are doing the ureteric catheterization. This is the injury of the ureter. So this injury was repaired on the table, and this catheter is removed after 1.5 months, and IVP was done. There was no any stricture of the ureter. So this video I have taken to show the complication in cases of the broad ligament myoma, which is two broad ligament myoma. And if we recognize the any complication, and if we treat the complication on the table, so then there will be no any litigation afterward. So drain is kept inside the uterine cavity. Second thing, whenever we do the myomectomy, port closure is also very important. One of my patient, so one of the my patient, you can see the port side
Voice.
hernia and bowel is already gone in the port side. So on the fourth post-operative day, patient is developing subacute intestinal obstruction. So the message is that always close the port after the morcellation. So I have not included the video of the morcellation because there is controversy whether we should the in-bag morcellation. Nowadays, in-bag morcellation is very suggested, and even you can remove the myoma after doing the colpotomy, and even mini laparotomy can be also done in cases of the multiple big fibroid. So, sir, thank you very much for the patient sharing, and sorry for interruption in the net. Thanks a lot.
Thank you so much, sir, for the wonderful lecture.
Yes.
I would like to ask our experts and chairpersons to give their valuable inputs.
Thank you, Dr.
Sir.
Desdipur. Very
Thank you,
nice
sir.
video presentation. And you have already clearly told that any myoma 4 centimeter above touching the endometrial cavity should be removed. And Dr. Jain sir has already told that any myoma inside the cavity, even submucous myoma, small size, can be removed for the better result of the IVF or any fertility treatment. Thank you, sir.
I will like to make few more comments as far as the myomectomy in infertility is concerned. Continue discussion with the size of the fibroid. So size of the fibroid, intramural especially, when we are talking of intramural fibroid, cutoff point is now going towards on the higher side. Previously it was 3 centimeter, then it became 4 centimeter, and now some of the recommendations say up to 5 centimeter can be left. But at the same time, there is some literature to suggest that if a intramural fibroid, which is towards the transformation zone, like at the junction, even if it is small, maybe 2 centimeter fibroid sitting near the transformation zone, that may cause a problem. Only thing is, these fibroids, if they are not bulging in the cavity, then it is slightly difficult to remove these fibroids even by laparoscopically, because they are very small fibroids. So mapping is very important. Mapping of the fibroids before going into cavity or going into the abdomen, number of fibroid, where they are sitting, whether they are small or large. I think these are the things which should be taken into account rather than only size. Then number of fibroid is again very important. If the total size of uterus is say 16-week size or 18-week size, then even if there are multiple small fibroid, they do cause problem of implantation and other things. So it is not only the absolute size, it is the location as well as the number of fibroids. That is very important. This Deepak has nicely highlighted the importance of suturing, because that is one thing which is anyone can remove the fibroid. There should not be any problem laparoscopically. If you are doing a myomectomy openly, then you will learn removing the myoma by laparoscopically. But when it comes to suturing, if you don't know the suturing, or if you are not very confident of the good suturing, then it is better to do open myomectomy if you are not comfortable, or try to learn the best technique of suturing perfect technique of suturing, because that is very, very important to avoid complication, to avoid rupture, and to avoid formation of hematoma postoperatively. So these things are very, very important. Use vasopressin to hasten the surgery, to avoid loss of blood, and suturing. So these are some of the important points in myomectomy, especially when you are dealing with multiple myoma. Another point, when you are dealing with multiple fibroids and going laparoscopically, try to remove as many fibroids with single incision. Of course, if it is a posterior myoma and other anterior, you have to give 2 incisions. But anteriorly, if there are 3 myoma, don't open them separately. Try to go through the myometrium, and again, the mapping will be very helpful in deciding the number of incision when you are going for the myomectomy. So I think these are some of the points which are very important when you are dealing with myoma, specifically in infertility patient. If there's any other thing, any comment, Dr. Parul, you would like to make some comment?
Sir, we
Dr.
can use.
Kuldeep? Yes.
Sir, we can
Hello.
use दोनों का.
You say.
हाँ sir.
Yes, I mean, MRI is an excellent tool if there are multiple fibroids to map them where exactly they are. And 3-dimensional MRI is now possible. So that will give you, because otherwise some myomas may be left behind and recurrence would happen. So whenever we are dealing with multiple fibroids, I always tell the patient that after 3 months, they should soon opt for pregnancy before the missed ones may grow or a new fibroid may come up. Okay. But I did highlight the point, perhaps you were not there at that time, that using resectoscope, if you are going to do a laparoscopy, then I don't think it makes sense, because we will give a large gap in the endometrium.
Yeah.
So instead of that, just put a cut if you want that to drain through the uterus. But I personally feel that many a times I have removed fibroids, submucous fibroid, but too large, and laparoscopically, the endometrium bulges like a balloon. And then we suture the muscle over it. The endometrium remains intact. So damage to endometrium will cause and will impact the fertility for sure. Some adhesions may happen. The healing may produce a niche there, like what we are talking about, cesarean section, isthmosil. Something of that sort also develops in some cases, not all.
Yeah,
So
agree.
that,
I agree, especially those myoma which are having a broad base in the
yes.
cavity. Now, these are very, very difficult cases to decide whether you have to go for histoscopic resection or laparoscopic resection. So one should be, the message should be, one should be open to change the route as per the requirement of the particular patient. So individualization is again very important. People say that all submucous myomas should be removed histoscopically. That is not right. That is the message. So if you are having a bite-based large myoma which is just bulging in the cavity, maybe it is better to remove laparoscopically rather than destroying more of the endometrium. So that is really correct. Another point which I will like to, recently it happened with me. We did the ultrasound, mapped and all that. Association of myoma with adenomyosis. Now these are the patients, if they are not pre-evaluated in the pre-operative period, might cause little difficulty when you are going for myomectomy. Like in this patient, the uterus size was almost 14 weeks, and there was a anterior myoma along with adenomyosis. Our preoperative diagnosis, because there was myoma, so it remained myoma only. Adenomyosis was overlooked basically during the pre-operative evaluation. And when we started doing myomectomy, we could not find myoma, or it was only thickened myometrium, it was all adenomyosis. But because we were sure that there is a myoma also, so we continued with adenomyomectomy, and then we found a myoma also. But myoma was only 2 centimeters. Rest of the thing was adenomyosis. So these are some of the challenging patients, and you just feel that retrospectively we thought that yes, we missed the adenomyosis because of the presence of myoma. So when you are doing ultrasound, you should keep that thing in mind. Both can coexist, and that might help in planning your surgery better.
So in cases of, I just wanted to ask a question, like in multiple fibroids of 2-3 centimeters of FIGO classification 3, and recurrent this we are doing IVF, and recurrent implantation failure are there because maybe of HOXA, this enzymes and all changes, anti-inflammatory changes. So we can combine, we have done in few patients, we can combine this our OPU needle for mapping of this fibromyoma, and then laparoscopically we can remove simultaneously.
How the opioid
We can use the OPU needle to localize the myoma. We can use the simultaneous ultrasound instead of hysteroscopy. Via laparoscopic, this ultrasound guided OPU needle, we can localize that myoma, and then we can insert the laparoscope, and because that fibroid would be outlined by that OPU needle, it would be easier to do a surgical removal of laparoscopic removal of that small fibroid.
No, I fail to understand what you are conveying.
I'm saying, sir, we can combine that OPU needle, which we use for aspiration of the follicles, ultrasound guided, TVS guided.
Agreed.
We can, if 2-3 small fibroids are there of FIGO classification 3, intramural there, then we can use that OPU needle to localize the fibroid. Ultrasound we can localize and then insert the needle there, and then simultaneously we can do laparoscopic and removal of laparoscopic.
So how would you locate the needle through laparoscope?
Needle we can
you have put it through the TBS, right?
TBS. So it will give a bulge. It will give a bulge there, and then
the pressure on needle.
Pressure on needle, or we can insert some fluid through that.
Okay.
We can insert
so instead of this getting the whole endometrium damaged by resectoscope and this, or using all the energy sources, we can do this in a less invasive way, and we can go to the patient in cases of multiple fibroids.
I would suggest best would be go for an MRI in multiple myomas.
No, multiple.
That will give you MRI will give you a good mapping
but,
of all those.
Mapping is there in MRI, but if mapping is good, if we are doing a open surgery, open myomectomy, then we can, then mapping is good, and then we can localize all the fibroids and remove it. But if we are doing a laparoscopic myomectomy, then many a times, even if MRI is available, it becomes a bit difficult to localize the fibroids, which have got no bulge outer side. Outer surface of the uterus is smooth, and if we consider posterior also, where we'll get the neck, and many times when we give a neck also, we are not able to find the fibroids. So we can
okay, have you tried this needle thing?
Yes, in 1 or 2 patients we have tried, and we have removed the fibroid. And in one case we have this endometriotic cysts are also very much common nowadays in intramural. In intramural region, endometriotic cysts are also very much common, and one time this pregnancy was there in the intramitral pregnancy was there, and that also we through OPU needle, it helped in localizing that sac, and then we removed it laparoscopically.
Okay. That is very interesting. I mean, I need to figure it out.
It is an
Uh,
interesting
So
thing.
Aim is to use all instruments, like all
Mm.
kitchen
But
utensils are used.
one point I
Histoscopically,
wish to make here, Dr. Deepak,
yes, ma'am.
uterine artery ligation to avoid blood loss has an issue, because if that patient has to have a pregnancy, we are doing it for fertility. So that pregnancy is going to be compromised if you have ligated the uterines this time. There are plenty of literature that uterines are as such end arteries. So when we ligate them, uterus will not slough out, but the overall capacity of uterus to increase the blood flow will be diminished.
We
So the
can,
pregnancy will have in placenta, which would be deeply going into the myometrium to collect adequate nutrients. So IUGR and those factors for the baby, adherent placenta would be an issue for us.
we
So
can
I
use
would,
the shoelace
we can,
technique. Use shoelace technique
exactly.
that
So it has to be removed.
removed
We
the
cannot
shoelace technique.
ligate it for the good. Okay. And vasopressin generally is a good enough option. Although in some countries in Europe, vasopressin is not allowed. And I have also run into a couple of issues of vasopressin. So one has to use it
Normal
with
saline.
caution.
We use normal
Huh?
saline many a times.
But normal saline may not produce that effect.
Yeah. Yeah, I know.
It may
Madam,
help in dissection. Yeah.
it means whenever we are doing myomectomy in FIGO 3, we should keep our sonography inside the OT and home pickup needle also inside the OT. If there is any doubt, you mean to say, because sometimes shifting the machine is very in some places difficult in the OT. So
See,
is
it
there
is
any
not
such
simple.
case?
Even if you do an ultrasound, because of the carbon dioxide inside, the picture is not so very clear. Okay. While doing a laparoscopy, simultaneous transvaginal sonography is not a very simple thing, and the delineation also is not so accurate as it would happen otherwise.
Very nice discussion. I think it will we will connect some other time. But because of the few other meetings lined up, I think we should proceed ahead. Ruchika, can you?
Yes, sir.
Further?
Yes, sir.
Um,
Thank you. I would like to
Deepak.
thank you.
Thank you, Deepak. It was really
Thank you, sir.
wonderful presentation, and thank you. I think a lot of
Thank you, sir.
messages through this discussion has gone, which will really help all audience. Thank you.
Thank you everyone for their valuable inputs and comments. Now, for our second session, I would like to invite our experts first. I would like to invite Dr. Parul Kotadawala, endoscopy. He's an endoscopy surgeon and consultant gynecologist, professor and head of Department of ONG Sal Institute of Medical Sciences, Ahmedabad. Sir is working as Kotadawala Women's Clinic, Ahmedabad, and is a senior consultant at Zydus Hospital, Ahmedabad. Sir has held various positions in different societies. Next, I would like to introduce our chairpersons for the last session. First, I would like to invite Dr. Anupama Bahadur. Madam is professor at AIMS Rishikesh. She's a founder secretary of IFS Uttrakhand chapter. I would like to invite Dr. Latika Chawla. Madam is additional professor, Department of Obs and Gynae, AIMS Rishikesh. She has established fetal medicine program at AIMS Rishikesh. She has established IUI and IVF facilities at AIMS Rishikesh. Next, I would like to introduce Dr. Ruchika Garg. Madam has done her MS, Obs and Gynae and fellowship in infertility. Her special area of interest are stem cell therapy in fertility, and she's received ISAR Mayor Youth Icon Award and ISAR Appreciation Award. I welcome all the experts and the chairpersons for the last session. I would, Dr. Mansi to introduce. Ma'am, would you like to introduce Dr. Mansi?
Yes, yes. Kindly share her CV. I'll introduce. Dr. Mansi Jain is a diploma clinical ART, fellowship in reproductive medicine and surgery, Singapore, consultant reproductive medicine and gynae endoscopic
Shall I
surgeon,
introduce her?
IIF and laparoscopy center, Delhi. She's a co-convener of SIG Endoscopy, IFS 2226, executive member of IFS, national coordinator SIG IFS, fellowship in reproductive medicine from Thomson Fertility Center, Singapore, fellowship in minimally invasive surgery from Max Hospital, Saket, presented papers in national and international conferences, written multiple chapters
Ma'am,
and
you're not audible.
lectures. I'm not audible. Why?
Oh, no, it's okay, ma'am. It's audible, Ruchika, I think.
Yeah, we can hear you, ma'am.
We can hear you.
Yeah. She's adept in advanced obs and gynae and ultrasound, keen academician and research with special interest in reproductive medicine, national coordinator ultrasound IFS 2019-21, organizing secretary of pre-congress. Okay, welcome, Dr. Mansi.
Thank you, ma'am, for such a kind introduction. I would just request you to give me a minute for sharing my screen.
Yeah.
Okay, so I hope my screen is visible. Can you all see my screen?
Oh,
Yes, ma'am. Yes, ma'am. It
My
can be seen.
slides are there.
No, your introduction wala slide is there.
It's not what you look at that matters. It's what you see. A very good afternoon, everyone. We all know that endometrium is a major determinant for success of any ART procedure. And Asherman syndrome is a very common and unfortunate condition, both for the patient as well as the clinician. So today in my talk, I have gathered some interesting case videos and we'll be dealing with them one by one. The classification of Asherman syndrome is very important for the correct diagnosis, the management, as well as the prognosis. So we have one from the American Fertility Society that dates back to 1988. We do not usually prefer this one because it also includes the HSD along with the HSD findings along with the endoscopy findings, as well as the clinical factors. So what we commonly use is the one by the European Society of Hysteroscopy given in 89. So according to this, the grade 1, it's based on the extent of intrauterine adhesions on hysteroscopy, and the grade 1 is when you see thin or flimsy adhesions which can be easily broken up by the sheath alone, and both the cornules are normal. Grade 2 is where the cornule areas are normal. A single firm adhesion is there connecting separate parts of the uterine cavity, and visualization of each tubal ostium is possible, and these adhesions cannot be broken by the sheath alone. Grade 2A is when the grade 2A is occluding adhesions only in the region of the internal cervical os. The upper cavity seems to be normal. Grade 3 is when there are multiple firm adhesions connecting separate parts of the uterine cavity. Unilateral obliteration of the ostium is there. In grade 3B, there is a combination of both grade 3 and 3A. And grade 4, the dreaded one, is the one where both the ostium are not visible and there are multiple adhesions occluding the cavity. Just give me a minute, I'll have this video started. The first case that we have here is grade 2 Asherman. So you can see we have entered the cavity, and on the right lateral wall, there is a thin flimsy band of adhesion. So we proceed ahead with hysteroscopic adhesiolysis. We are using a micro scissor. This is the fundus, and on the fundus also you can very well appreciate the thin bands of adhesions. So this is a very easy case to operate on. Easily it can be dealt with the hysteroscopic scissors, but a couple of things have to be kept in mind. Firstly, the tip of the scissors always has to be under vision. You have to begin your dissection from the center of the wall. You cannot be too high up or too down low. It has to be in the center. The direction of the scissors has to be perpendicular to the cutting surface. And you have to proceed in a very controlled manner. Small controlled nicks have to be given. Avoid overzealous adhesiolysis, or you may end up going through the myometrium. So keeping all this in mind, you proceed with adhesiolysis, visualize both the walls, both the ostium. That is very important. So usually these are the cases which are very easily dealt with hysteroscopy. Easy surgery is very rewarding, very satisfying to watch. The trick lies in making the right diagnosis, because there are subtle lesions which are usually missed on ultrasound. So one needs to keep a very high index of suspicion. Persistently thin endometriums and all, you have to be very suspicious. And here lies the importance of a good meticulous ultrasound scan. Of course, you can take help of color Doppler and 3D, which makes the diagnosis easy. And you can see that's the end of the video. These were the pictures. You can see, you can appreciate very well, thin, flimsy bands of adhesions are there. And this is the final picture after correction. Coming on to the next video. So here we can see a combination of adhesiolysis with lateral metroplasty. Now you will appreciate this cavity is full of adhesions. Both the lateral walls have what seems like dense adhesions, and even the fundus is full of dense adhesions. So again, we proceed with the adhesiolysis. Start from the center of the fundus and proceed gradually. You proceed laterally. So it's always important to start from a midpoint. Always the direction of the scissors has to be perpendicular to the dissecting surface. And you can see, you will appreciate with good distension, and when you gradually move towards the lateral sides, the cavity itself, it starts opening up and you're able to visualize it better. This is the part where this is a lateral wall, and it seemed like dense adhesions. Initially, we thought we could proceed with the scissors. So this is how we start. You focus on the area where you intend to start dissecting, start from the center, but you can notice it was really difficult. The adhesion, the bands were very dense. So these are a few cases where, usually we are dealing with fertility patients, so we avoid using current. But these are the few cases where using a energy source might be a good idea. So you can see in this case, I have used a unipolar hook, and it makes the whole dissection process a lot more easier. Again, a couple of things that need to be kept in mind when you're using any energy source. So it always has to be under vision. The tip always has to be under vision. Again, start from the center. The direction of the unipolar hook is extremely important. It has to start from the fundus coming towards you and not the other way. Otherwise, you can land into a lot of problems. And it has to be a controlled motion. Avoid making irregular small nicks here and there. It has to be in a controlled manner in one go. So that's the cavity. Try and restore as much as the cavity that can be restored. Moving on to my third case. Now, this is a very interesting case, mainly because of the case history. You will see there are multiple bands of adhesion, thin curtain-like adhesion stretching from the anterior wall to the posterior wall, making multiple holes in between. So again, these are the cases which are very easy. I believe they're easy to diagnose on. They easily present on ultrasound. And when you're doing hysteroscopy, you can easily go in a controlled manner, start in the center, start adhesiolysis. You will see they're easily breaking away. The reason why I included this case was because this patient, when she came to us, she had already had 5 cycles of IUI. When we looked at the follicular monitoring reports, the ET was consistently, it was around 5.5, never exceeding 6 mm. But she had continuous back-to-back 5 cycles of IUI, and that is when she got fed up and she came to us. So these are the cases that can easily be diagnosed in ultrasound. So one has to keep a very high index of suspicion, and any persistently thin ET should be investigated. So you can see a panoramic view in these cases always gives the best information, because earlier this was looking like one of the ostium, but when you move your scope a little bit in a panoramic view, you will see that was just a band of adhesion. And now you see we've entered inside the upper cavity. The fundus also does seem to have some adhesions, some doubtful. Yes, you can see there are some thick adhesions here also. So, like I said, easily dealt with the micro scissors. So I'll just stop it here and move on to the next case. Okay, so this is a typical case of grade 4 Asherman. As we entered the cavity, this was a very small I am so sorry. 1 second. Yeah, so as we entered the cavity, it was a very small cavity with the anterior wall almost plastered with the posterior wall. Only about 20% of the cavity was visible. It was almost like a tubular cavity. Now, these are very challenging cases because these are the cases where usually the only landmark you have is the point from where you have introduced the probe. That is the internal os. Both the ostia are not visible, and to decide where exactly you will start your dissection is the main problem in these cases. So here you can see there is a small, I don't know if my cursor is visible or not, but there is a small window we can see, and next to it are these bands of adhesion. So we decided to start from here, and once you find the right point and the right plane of dissection, things become a lot more easier. So you have to be very patient, look for the right place where to start for, and then gradually move laterally. And I have obviously fast forwarded this video. It seems a lot better now. So you can see we are gradually moving in the horizontal plane towards the other cornu. And these are the cases where using laparoscopic aid or intra-op ultrasound does seem like a good idea. So usually for all cases of grade 4 endometritis, we luckily have an ultrasound machine in the OT, and we take a lot of help of the ultrasound, intra-op ultrasound guidance to avoid the major complications like perforation or creating a false passage. Also, another thing that has to be kept in mind when you're dealing with these cases, because these are the cases usually they take a lot of time and thus they require a lot of fluid. So fluid overload is one complication that we need to be watchful for. One designated person has to be there in the OT who's just taking note of the fluid overload and noting the fluid deficit. If at any point of time it exceeds 1 liter, you have to be extremely cautious. Above 1200, definitely you abort the procedure, close the procedure. Even in patients who are a bit on the compromised side, you have to be careful after 700 ml because these cases are very prone for these kind of complications. Another thing to note in these typical cases is that the management of the patient does not stop at hysteroscopy. Of course, the aim is to recreate as much of the cavity as possible, but the management does not stop here. Post-op management for these patients is equally important. So, prevention of post-op adhesion formation is very important. At present, there is no general consensus or a guideline that says which of the modalities is better. So commonly done things are putting a Foley's catheter intrauterine or putting an IUCD. But we being infertility specialists, we prefer hormonal therapy. With the estradiol valerate, which should be given minimum for a period of 6 weeks, maybe extended up for 8 weeks also. And they require endometrial evaluation to see the extent of the correction by TVS. Of course, color Doppler helps in prognosticating, and the endometrial characteristic and everything you can see. So post-op follow-up for these patients is very important. And these are the patients who should be counseled beforehand for a second look hysteroscopy, which is mostly required in these cases. Now coming on to the next case, this is a very interesting case actually. This patient, she had infertility and she had a huge uterus. We were not able to get a proper section in the TVS scan. And so we had to do a transabdominal scan, and you can see she has adenomyosis, and if you just focus at the ET, it was quite irregular and thin. You can see here And I'll also show you the 3D pictures. So we took the 3D picture. The cavity seems like really distorted. So I would like to, the reason I put in here, because this is not the ideal 3D picture. If you look here in the second film, you can see a thin ET. The cavity, I hope my cursor is visible. So the cavity is here at the extreme end, and the black lines is the transformation zone. So again, it highlights the adenomyosis that is there, but also the element of endometritis which is there. So let me just show you the pictures first. So this is what we got when we went in the cavity, and on the first look you can appreciate very well that it's almost like a bald endometrium with minimal proliferation, patchy areas of vascularity. There are adhesions on the lateral wall, dense adhesions. The ostia were also almost obscured. We could see them, but a lot of periosteal adhesions and all were there. Sorry, I will just take 1 minute because I wanted to show you the video also. It was too huge, I couldn't fit in here. So just 1 second, I will take. Okay, I hope my video is visible.
Yes.
Okay, good. So, like I said, there were dense adhesions on the lateral wall, and then we did proceed with the lateral metroplasty. And they were very thick adhesions. One of the scissors just broke, but still we were continuing with the scissors only. What I wanted to show here was that actually this cavity was deviated because probably of the adenomyosis. So you can see initially I started the adhesiolysis, the lateral adhesiolysis, lateral metroplasty, but I went completely in the wrong plane because I had to frequently just keep on changing the orientation. So that is a very important point to note. These surgeries look very easy, but the basic points you have to keep in mind that the orientation should be maintained at all times. So because this was a deviated cavity, so again and again it required correction. And once I was back on the track, it was quite fulfilling, and we were able to correct the cavity. I would have loved to shown the post-op follow-up ultrasound pictures, but this is a very recent case and it's only 10 days old. So we have put her on estradiol valerate. I am sorry, I'm just not able to close my video. Just 1 second. Okay, coming back. So this is the last case. It did seem quite interesting, so I just wanted to add it here. So this was a typical foreign body along with endometritis. Now this is actually highlighting the usefulness of the ultrasound. So you can see there is a linear hyperechoic area in the middle of the endometrial cavity. This patient also had oligomenorrhea. But the point to be noted here is that if you look in the lower cavity, you can see kind of a thin and irregular sort of an endometrium with some amount of fluid. So no doubt, when we did 3D, it was a foreign body, and anyway hysteroscopy was planned, but we did have a high suspicion of endometritis. So let me just show you. These were the pictures. She did have endometritis. You can see this is one of the cornu, and this was the cavity. And of course, the foreign body, which was probably a RPOC that was there in the cavity. So I'm not showing you the video. You just simply grasp the foreign body. So this is our data. This is actually our 5-year data. This is old now, before 2018. But still, I think it's relevant. We operated a total of 500 cases, out of which only 55 were abnormal. And most commonly, we encountered Asherman. So these are the findings, abnormal findings of 55%, and about 30, all were corrected and 35% were able to conceive. Coming on to the multi-dollar question, can we improve the endometrial thickness? Well, without a debate, hysteroscopy has a very essential role both for the diagnosis and the treatment of intrauterine adhesions. There is no doubt about that. Some other modalities like use of estradiol valerate, definitely without any doubt, they do help. But other techniques like changing the protocols, using sildenafil, using GCSF, using intracavitary PRP. So all these things we have been doing in the past, we are still continuing to do so, and the results are also, there is improvement. Although they do seem to be very good and all that, but till date we do not have a clear cut consensus. We do not have a definitive guideline, and there is no standardization, especially for PRP. Everybody is doing PRP, but there is no standardization. So it's high time we are more clear about these things. And also an important point for dealing with the Asherman syndrome, multi-disciplinary approach, in the sense you have to take help of ultrasound, you have to take help of endoscopy, the clinical picture and everything. So everything put together completes the picture. Thank you.
I invite Dr. Latika Chawla to conclude the session.
Lovely videos, Dr. Mansi, and I must congratulate you on the volume of data, the number of patients you have worked upon. Just wanted to say one thing, that the role of PRP is big time there for women with thin ET without Asherman. But with Asherman, the role is still like kind of doubtful. So we are not sure if PRP is working in women with thin endometrium as a result of Asherman syndrome. But a phenomenal amount of work you have done, and wonderful lecture.
Here I will like to say we have done a large study, effect of hysteroscopy and PRP in thin endometrium. Now I can very well say, after analyzing, that PRP is more beneficial when you are having a pathology corrected. Once you are correct a pathology, PRP is certainly going to improve the outcome. The data is doubtful when you are not having anything to correct on hysteroscopy, then PRP may not be very helpful. So that is our analysis, the large data, almost 300 patients, where we have corrected the adhesions or corrected the pathology, and then we use PRP. Certainly the preoperative and post-operative analysis was really remarkable improvement. But when there was no correctable pathology, only thin endometrium, their role of PRP is still remains to be resolved.
Dr. Mansi, wonderful session, and very confidently you showed all the videos, and you were very much well versed with your subject. That was very good. And I just wanted to ask, in cases of adenomyosis, persistent thin endometrium is there. We are giving this estradiol hemihydrate nowadays. We are switched from valerate to hemihydrate now. And then also this endometrium is not growing. And we have done hysteroscopy also, like sir was saying, that if PRP will work, if anything positive in hysteroscopy is there. So in that case, lateral metroplasty will help in that cases of endometriosis, adenomyosis, in which whole transition zone is involved of endometrium and myometrium.
So ma'am, these are really challenging. Adenomyosis cases are generally very challenging cases, because you saw, like in this case, to delineate the endometrium itself is a major challenge. At many a times the ET is there, but you need to get the right plane to focus on the ET. So but like in this case, there was an added factor of endometritis along with it, and that too grade 3 endometritis. So hysteroscopy as a routine practice, we do only if there is a known endometrial factor along with the adenomyosis. If it's only an adenomyosis, yes, there'll be difficult to get the right kind of ET. I don't think it will be persistently thin. It may be a difficult, ET to get. What we do as a routine practice, what we have started doing is for all cases of adenomyosis and especially severe adenomyosis. So we retrieve the eggs, we give agonist for a period of at least 3 months, and then we work on the endometrium and then we transfer. So this has given us a better result rather than just fresh transfers in these cases.
Yes. I totally agree that fresh transfers we are not doing, and we freeze the eggs, embryos, and then transfer. Then also in meantime, 6 months or 3 months, we have to prepare that endometrium. Even if we have got good, and if we are not giving a good endometrium after a gap of 3 months or 6 months to the patient, and we are saying again and again, because in my personal experience, I want to share that they have got a very short follicular phase. And at 5 or 6 only, this follicular phase changes to luteal phase. So that phase we have to capture in that endometriotic patients, adenomyotic patients, and in that phase only we have to go do the embryo transfer and start a LPS. But the crux is that in few chunks of patients, we are not able to get that short follicular window also for the transfer. So that patients keep on nagging us and repeatedly. And if we do transfer also in these patients, the result will not come to be positive.
So, like I said, yes, they're very challenging adenomyosis itself, and if it's compounded by an endometrial factor. So, I think if with adenomyosis, if you're getting a persistently thin endometrium, even after changing your protocols, you're getting a persistently thin endometrium, then definitely you need to put in a scope to see if there is an associated endometrial factor. Now, it may be a mild endometritis, but if you're getting a persistently thin endometrium, then yes, definitely put in the scope. If it's a case of recurrent failure, so we know, yes, one factor is adenomyosis for sure. So then depending on case to case, if you've tried enough of medical management, then it may be a good option to, before canceling the whole thing, go for a hysteroscopy along with the resection of the adenomyoma. So in cases of recurrent failure, I think that also might be one of the things that can be done.
You have to look at the BMI of the patient also in these patients. Many times these are overweight, and a weight loss of 5 or 6 kg may help in getting the endometrium improved.
Okay, Dr. Mansi, one last question I have before we conclude. So, what has your experience been between TB and non-tubercular patients post addusiolysis? Like, is there a difference in the endometrium in those two groups of patients?
Okay, so ma'am, as a routine practice, yes, we do send for TB PCR and AFB culture, and TB is definitely TB with really bad cavities like grade 4. Definitely, the prognosis is really bad. So it's not a very flowery picture compared to other, because recently we have started using DICE panel, which is a PCR for all the other organisms like the anaerobes and like the lesser common ones. So I am compiling that data. But yes, I mean, if I just grossly comment on this, TB is definitely much worse than the the other gonorrheal infections or chlamydia and etc. But I don't have conclusive data. We had just I think it's been last 6 or 8 months we have, as a practice now, started doing extended DICE panel for all patients which are highly suspicious of endometritis. So I hope very soon we'll be able to present that data as well.
Okay, lovely. Because our picture with tuberculosis patients has been very, very gloomy, actually.
It is a very difficult and challenging. Most of them, they drop out. Even like there's so many cancellations, 3 times, 4 times you're doing, and eventually they drop out. But like not all cases, maybe like around 15% benefit. So
okay.
Our next chairperson, Dr. Ruchika Garg, is also with us. Dr. Ruchika?
Definitely, ma'am.
Kindly
Hello.
Yes.
Yes, ma'am. I have Dr. Mansi, it's a wonderful presentation. I have just single question as ma'am has mentioned that there is a patient with adenomyosis, a thick adenomyoma, and the patient is not responding even with estradiol hemihydrate. She is not responding with PRP. There is no Asherman syndrome, and the lining is persistently thin with history of previous 2 IVF failures. And how we should proceed in such a patient, because I am dealing with one such a patient, and I'm really finding it difficult to build up the endometrium.
Okay, ma'am. So I think in my personal experience, I would also like the experts, Dr. Parul sir and Dr. Kuldeep Jain, to comment on this. But I think these are the perfect patients when you've tried all medical means. So I think they should be given a fair trial with surgery for adenomyosis. So resect as much of the adenomyoma you can take out, and obviously when you're doing a adenomyomectomy, do a hysteroscopy also. So I think these patients do benefit from that. So, but I would also like to hear what the experts have to say
It
about
is a
this.
generalized adenomyosis.
It's generalized.
It's not.
But I feel still you can do a little bit of debulking, as much of it as you can get. I know the
Debulking.
generalized ones are very difficult to operate on. They are very messy, and but I still feel getting a little bit, I mean, as much of the tissue as you can, get out. I think it does help.
And even after giving a leupride long protocol,
Yeah, so failed medical management
Yeah,
basically.
yeah.
I think these are the ideal candidates for adenomyomectomy or
Okay.
resection of the adenomyoma. According to my practice, I
These
feel that.
patients
Yeah.
actually who are having multiple failures and endometrium is not coming, receptivity is poor. Certainly, we at one point of time, adenomyomectomy is justified in this patient. They do respond to your adenomyomectomy, and when combined with uh, down regulation for 3 to 4 months, certainly hysteroscopy, how helpful it will depend on the vectored endometritis uh, along with adenomyosis. So these are the patients where the extended panel is suggested. Extended panel for ureaplasma, mycoplasma, chlamydia, gonorrhea, and anaerobic organism. And as Mansi has highlighted, uh, we are finding a lot of patients who are having these organisms. They are not having tuberculosis, but other sort of organisms are getting we are getting there, and probably if you treat them, they will be better along with the adenomyomectomy. So you have to have multi-pronged approach, improving the implantation as well as improving the receptivity by treating the infection and treating the inflammatory conditions. So that will really help in these patients. Dr. Parul, what is your take?
No. I mean, this kind of infections where you can see them on hysteroscopy, they are bad infections. The endometrium has already got damaged. I would rather focus on those where we are not sure. And so many times, I mean, I have a routine practice of doing TB-PCR on all pre-IVF hysteroscopy. And I have found significant positivity rate. In these patients, when we give them anti-tubercular regime, some of them, about 20%, become spontaneously pregnant. So that is something which I wanted to highlight. And second thing was, Mansi, can you assess the endometrium by hysteroscopy? Somebody else's, echo is happening.
So I didn't quite understand, so I couldn't catch the question.
So assessment of endometrium by hysteroscopy, whether it is thin or not, how would you do that? Only ultrasound or hysteroscopy as well?
So the diagnosis starts from ultrasound. We would never take up a patient straight for hysteroscopy without doing an ultrasound. So ultrasound is the first step. on hysteroscopy, there are these markers when you take note of the proliferation, you take note of the vascularity and presence of any structural defects or adhesions and all. So that is how you grade it and put it into the categorization. So
So on
definitely
which
it is
day of menses would you assess the endometrium?
so
Hysteroscopy.
we do it post-menstrual around day 8 or 9 or 10.
So do it in the later part of proliferative phase. Otherwise, it will be thin anyway. If you do it immediately post menstrual,
Yeah.
it would be thin, and you won't be able to judge that. So
Yes,
my
yeah.
practice is always to do it at day 12, 13, and then press your hysteroscope onto the endometrium, and then see how much of a pressure effect you get. If there is a good pressure, or rub your scope onto the endometrium, and if you can make a good groove, that is a good endometrium. And if you cannot do that, it is a thin endometrium, likely to have some infectious pathology.
But sir, I'd like to ask, so does these findings, do they correlate well with the ultrasound picture?
The problem comes when you do an ultrasound, it gives you a hyper echoic endometrium. Then you are worried whether this is a good endometrium or not. A triple line good endometrium is fine. Then there is no question about it. But sometimes we do find hyperechoic or isoechoic endometrium. You cannot see that proliferative kind of. In this cases, you can judge the thickness of endometrium. I'm sure it is not very accurate, you can call it. But then it is not just the thickness, but look at the quality of endometrium, and that will give. So for fertility, when we are evaluating, I would avoid immediate post menstrual phase, go little bit on the later part of proliferative phase. Okay. Otherwise, nice cases you collected.
Thank you, sir.
Thank you, Dr. Mansi.
I invite our Joint Secretary of IFS UK, Dr. Vidushi Jain, to conclude the session.
Okay, sorry, one point on
Yes, sir.
adenomyosis. See, we should not have a fixed idea that it has to be a laparoscopy. You can open up the abdomen and do adenomyomectomy or reduction of the adenomyoma when it is diffuse. Okay, because the suturing and quality of repair is much better in open technique than a laparoscopy. So don't make it a prestige issue that it has to happen only with laparoscopy. Okay.
Very
But
nice.
with, yeah.
Nice point.
Same thing is true for even fibroid, very large fibroid, 10 centimeter, 12 centimeter. We can do it. But the question is, can do it and should do it should be always there in our mind. Whether it will benefit your patient. If your surgery will go on for 3-4 hours, you are doing it under general anesthesia because you need to remove that fibroid with a morcellation. And your suturing of such a large gap may not be as good as an open surgery. In such situations, you can remove the fibroid from the bed, make a small incision and remove the myoma, but I would even prefer sometimes spinal and do it open way. So according to patient condition, obesity is one situation where I would prefer a laparoscopy. But otherwise, if it is a very large myoma, an open would be a very good option.
So we can conclude the session now?
Yes, please. From my side, yes.
Thanks to all stalwarts, Dr. Kuldeep Jain, Dr. Varun Gurdwara, for such showering such immense knowledge on us that would be helpful for our patients' treatment. And many thanks to both the speakers, Dr. Desh Deepak and Dr. Mansi Jain, for your excellent presentation. Thanks to all chairperson and experts joining this IFS webinar. And we hope to have more such webinars.
Definitely, ma'am. We can even have some physical CMEs in the future.
Anytime.
So we would love to associate with your
With
Definitely.
Mansi in the team, you be ready for many programs. She's a live wire lady and very perseverant.
Yeah.
Thank you, sir. Thank you
Yeah.
so much.
She's right
Thank you, ma'am, for all the cooperation from your end. And yes, definitely we look forward to many more associations in the future. And I would also like to thank all the experts, Parul sir, Deepak sir, Dr. Kuldeep Jain for giving their valuable inputs and being here in person, and all the experts from Dehradun chapter and Uttarakhand chapter. Thank you, everyone.
Thank you.
Okay.
Thank you, everyone.
Thank you, everyone.
Bye-bye.
Bye.